Hey everyone, welcome to another episode of Medical Minute.
I'm Dr. Rick.
And I'm Dr. Danny.
We're excited to bring you a special guest today for this two-part episode. We told it's going to be two parts because I think we're going to have a lot to talk about in colorectal cancer.
That's right, Rick. We're so happy to be here with Dr. Alex Crean. He's our special guest today. Welcome, Alex.
Oh, thanks so much for having me, guys. I'm excited to be here.
So, Dr. Crean, if you could kind of give the listeners sort of your background, where you come from, how you ended up being a excellent colorectal surgeon.
Yeah, sure. So I'm a colorectal surgeon over at Memorial Hospital, and I've been here for about 3.5 years. I grew up actually in Augusta, Georgia, so not too far away. That's where I did my medical school. I did my general surgical training up in Philadelphia, and I did an extra year of colorectal training in New York, but wanted to come back down south. So Jacksonville was a natural fit for us, and we love it down here. And I really focus on taking care of only colorectal problems, both benign and malignant, in terms of colorectal cancer for the patients of Jacksonville.
No, I think, I guess that's the part we probably don't see too much is the benign side of things. And obviously most of this talk we'll talk about colorectal cancer, but Alex, what kind of things do you cover on the benign spectrum that you manage?
Yeah, so that's the stuff that really pays the bills. Hemorrhoids, any kind of anorectal problem, pain, bleeding, things like that. We do take care of patients a lot with diverticulitis as well, which is a benign condition that affects a lot of Americans. But then, really the passion is taking care of the colorectal cancer patients as well, because it's a whole different treatment population than the benign patients.
I think, part of the reason we wanted you to join us today is taking care of cancer patients in general, but especially colorectal patients is a team approach, multidisciplinary, involving not just, us doctors, but, nurses and coordinators and nutritionists and everything all along down the line, radiology, pathology. So we can kind of get into some of that. I don't know, Danny, do you have any thoughts about sort of just kind of that multidisciplinary approach to rectal cancer care?
You're exactly right, Rick. I think it's key to have great communication between all of us. And I think as the guidelines change, we have our own, spots in the care and how we deliver chemotherapy on my side of things with medical oncology. But we have to be in constant communication about the timing of how we sequence our therapies. And it really helps to have good communication with you, Alex and Rick, and just making sure that the care is seamless and that we get the patients through it with hopefully, manageable toxicities.
Yeah, I agree. It's always tough to get the diagnosis of colorectal cancer. Obviously that, no one wants to hear that. But I try to encourage patients that now is a good time if you have to have something like that to deal with it. The treatments are very well tolerated. It's not the same kind of diagnosis you would get 20, 30 years ago. The technology with chemotherapy and radiation is excellent. We do our part with robotic or minimally invasive surgery. And it's just very different than if your parents or grandparents had the same kind of disease. It's a much better outlook.
Yeah, I think it, like you were saying, Danny and Alex, it changes by like the year. I feel like there's always something new or, coming along the pipe that you may not even think about and realize, and turns out it's going to be a big change to practice. Yeah, I think one of the things we should talk about before we kind of get into the weeds of some of the specifics of how colorectal cancer is managed is sort of how is this picked up for our, patients' families who are listening. What are things they should look for that may prompt them to seek medical attention? And then, of course, we should talk about screening with colonoscopies and other things. I don't know if either one of you wants to jump off on any of that, but what are some of the things you routinely tell, patients, and what should they be looking for or what should they be thinking about?
It's important, I think, to differentiate between all the new tests we have available to detect cancer. We have blood tests, we have antigen-based tests to test the stool for different possible markers of cancer, and then we have colonoscopy, which still is the main way we detect precancerous polyps to remove them before they turn into cancer. So I advise patients to really adhere to the guidelines about when they should undergo their screening colonoscopies. Some of it's based on risk and their family history. I think Alex can dive into that a little bit more, but these blood tests and stool tests are not replacing colonoscopy, and unless you have a patient who's extremely low risk who opts against colonoscopy. So Alex, could you tell us a little bit about how you use colonoscopy or even sigmoidoscopy in your practice?
Yeah, absolutely. I think that's talking about the benign stuff. It kind of does tie in with this because more often, sometimes we'll see a patient that gets sent over for a presumed benign condition, such as hemorrhoids. Maybe they're having some bleeding, and maybe they're pretty young. They could be in their 20s, 30s, early 40s. But that's why we always have to talk about the risk factors for colorectal cancer. And some of those can be if you've had a family member with previous colorectal cancer, especially if they had it at a young age, and if it's either a brother or sister or mom or dad, a close relative. If you have any other exposures or known risk for such as inflammatory bowel disease, so that's Crohn's disease or ulcerative colitis, something you want to pick up, or if a family member had it. If you're having those risk factors, it's reasonable to do a colonoscopy, either with a surgeon or a gastroenterologist early, because right now we know the new recommended age is 45, but it's not unreasonable to do it to someone in their 20s. That's the best way I think to treat colorectal cancer is to screen for it and pick it up before it ever happens. So if you can have a polyp removed by a colonoscopy, that can save you a lot of treatment down the future. So it's always reasonable to ask.
Mm-hmm. Yeah, I think that point about the age being lowered speaks to, I think, what we're seeing both objectively, what the literature is showing, but also anecdotally. I think we're all seeing, unfortunately, younger and younger patients get diagnosed with colorectal cancer, even those without any clear risk factors or strong family history. And so I think there's clearly some sort of shift in the epidemiology of this disease, and I think screening guidelines are catching up. And I wouldn't be surprised if that age gets pushed lower, over the subsequent years and decades. I guess one question I've always had, Alex, in your practice, obviously folks with inflammatory bowel disease or other things, you would recommend usually some sort of colonoscopy at the minimum. How do you guide patients with maybe things like hemorrhoids or something maybe on the more benign end? At what point would you maybe say, okay, now would be the time to do it, even if they fall outside that standard guideline window?
Yeah, for example, if we're seeing a younger patient in their 20s for hemorrhoids, and I examine them, I do what's called an anoscopy, which is a very short scope of just the anal and rectal area. If we visualize hemorrhoids that look substantial, we undergo treatments for that. That's either office-based or surgical. If those patients are doing great, their symptoms resolve, and they're young, probably okay to just watch them. But if we don't find anything terribly impressive on examination, or despite treatment, the symptoms aren't resolving, especially bleeding, I think it's very reasonable to pursue something else like a colonoscopy, because not to try to scare people, because it's still very rare in young patients, but there are patients that are well below the screening age that we're picking up colorectal cancer in.
Mm-hmm. Yeah, I think, you're seeing, obviously, patients who are already getting to you, of course, are going to be more likely to have some sort of, issue along the GI tract. So I think it's very reasonable what you're describing, and certainly what we're seeing with the younger age of patients getting diagnosed.
And Alex, you're seeing patients at a younger age independent of inflammatory bowel disease, a lot more cases.
Yeah, we are seeing younger and young patients, without any identifiable risk factors that are sometimes, even in their 20s, showing up with colorectal cancer. So it never hurts to ask, if you have a primary care physician, if you have a gastroenterologist, OBGYNs, never hurts to ask, because you can always be screened. I don't think you're ever going to regret it. If there's nothing, then great. Then you're good for 10 years. And if we find something, then we found it early, and it's much more treatable. I think the earlier we find things, even if it's not good news, the treatment options are much wider than if it's found later in the game.
Yeah, I think the important point is not to ignore bleeding, because even if it comes out benign and due to hemorrhoid or some other cause, no harm or foul there, that you're getting checked out and making sure that you don't have a condition which could take your life in the end.
Yeah, I think you took the words out of my mouth. It's so easy to ignore, those symptoms and put them on the back burner. And obviously we're all busy and doing a million things, but at some point, it can be a way your body's trying to tell you something, for lack of a better way to think about it. But
what got you into colorectal surgery? Now you go through a general surgery residency, right, and then kind of opt for fellowship. Yeah. What kind of directed you into that specialty?
I like to say I did it for the jokes.
All right.
But
you can help me out then. Yeah. That's for sure.
Yeah.
It it provides a.
Yeah, I noticed you didn't have a joke
I do
prepared.
have a joke today, but I'll tell it at the end of
Oh,
the
okay.
Looking
episode.
forward to that. That's why I came actually. For the joke.
Darn it.
It's a really wide range of disease processes across a lot of ages. You know, we can
Yeah.
see inflammatory bowel disease patients in their their teenage years. I see people all the way up to in their 90s, and it spans from inflammatory bowel disease, rectal disease, colorectal cancer. So you see a lot of different types of people, a lot of different types of personalities. And then the treatments are very variable. We do very big surgeries, robotic surgery, where we're taking out parts of the colon, putting people back together, and then we take care of very small things where we do office-based treatments for hemorrhoids. So it doesn't, to me, it never gets monotonous, and you just have a very diverse range of conditions that you're able to help people with. That's what really drew me to colorectal surgery.
Yeah. Now, when I think about seeing a new patient with colorectal cancer, I'll tell the audience treating colon cancer is different than treating rectal cancer. So we have different algorithms for that. But how would you say the treatment surgically has changed, say, over the past 5 to 10 years, when you have a new patient who is a surgical candidate to remove their colon cancer? And typically that's done with removing part of the colon. How have the modalities changed for the better, and I think only better? I doubt it's gotten worse over time, but for the better, how would you describe that?
Now that's a great question. I think when we're seeing people for the first time that have a newly diagnosed colorectal cancer that potentially needs surgery, everyone has in the back of their mind, the mother, cousin, brother that had an ostomy bag. Am I going to need a bag for this? The answer to that is almost always no. So we're able to really eliminate that, do stuff more electively. With robotic laparoscopic surgery, we're able to do the same surgery that was done before through a large incision, through multiple small incisions. And we're really seeing that helps speed up recovery, it helps minimize pain, it helps people take less narcotic pain medications, which is crucial in today's medical world. And then it gets people to whatever other treatment they may need faster. Will it be chemotherapy, radiation, because you're not having to worry about healing a large incision or anything like that. And it's really changing the way we surgically can treat patients. And we can do things for patients that are much older or sicker that before may have kind of gotten written off and said, you're not the best candidate for anything, not much to do.
I think obviously just speaking anecdotally and secondhand wise, I think what's crazy to me to see is some of the operations that, Alex and other colorectal surgeons can do in these patients who, I think before we would have said, oh, maybe they couldn't handle or tolerate a larger surgery, but these folks, come out great. And they're out of the hospital in like no time. And, we see them a few weeks later and they look like they barely had, anything happen. And that's what they report too. So I think it's a testament to your field and y'all's skill level that these things have evolved over time.
Yeah, that's where the team approach really comes in, though, because we're communicating. I try not to do surgery in a vacuum. I know enough about the chemotherapies and the radiation to try to factor that in, where maybe my part is done, but then I'm hurting the next part of treatment. So that's why I think the communication is key that we all have.
Yeah, I think we'll probably hit on it a little bit more later, but a tumor board or a multidisciplinary discussion, in my opinion, for these cases is absolutely mandatory. Outside of an emergent situation where something needs to be done to save somebody's life, I really think that, get the opinions of everyone, not only our 3 specialties, but all the other specialties that are involved in cancer care. So a recommendation can really be made where it's not done in a vacuum, as you said, and it's really done taking kind of the whole, patient picture into context and what the different treatment options are.
Right. There are a lot of ideas that are thrown out in tumor boards, and there may not be one right answer for the case, but I think you get kind of the consensus and you get the right approach to treatment majority of the time. How have you seen the shift to robotic surgery now compared to prior, where you were doing more laparoscopes or even open surgeries? Are you using robotic in a majority of your cases?
For me, unless it's actually, even if it's urgent or emergent, sometimes we're able to do it robotically. But for everything that's planned, we take a robotic approach. And patients know, if they've had significant previous surgery, if they've had something else, happen intra-abdominally, there's a chance we may have to make a larger incision. But we really do our best to try to do it robotically, just to minimize the physiologic insult to the patient. And it really does let us do more for a wider range of patient population.
and the precision of what you're doing is much better with the robot compared to doing laparoscopes?
Yeah,
and that
so,
sort
you
of
know, the way, you know, because some patients kind of misperceive it, and I don't blame them,
Mm-hmm.
that, you know, the robot's really doing the surgery. I think at some point that will come,
Mm-hmm.
and they won't need us anymore. But right now, I basically
in the
tell them,
future.
like, it's a very, very fancy scalpel.
I
You know,
see.
it allows me to be in spaces, either in patients that are maybe a little bit bigger,
Right.
or have had something else done before that would be very limited visually, laparoscopically, and we are able to do make very fine movements with these robotic instruments, but it's still us controlling it. But it's a game changer, I think, for the treatment of colorectal cancer.
How is and a little bit of being naive to the process and being in there with the robot, but how is the visualization improved? And you touched on it being much better, but what kind of technology is there to make the visualization better?
Yeah, so it's a neat technology where basically the robot is attached to the patient, and it's communicating through these small ports that the instruments go through, and then there's a camera, and the way the camera generates the image on the console where the surgeon's sitting, it's almost a 3D image. So things look bigger than they are inside the body, which allows us to see better. And the precision, the accuracy of what you can see, into some of these planes, tissue planes in like tough rectal cancers, that can make a lot of difference in how someone's going to do surgically. For me, I think it really adds a lot to the surgical treatment.
Yeah.
I mean, I think I only have the experience of, being an intern or a med student and sitting in on some of these, but just the difference from a student's perspective when you're, looking at the laparoscopic ones I attended versus the robotic ones. I mean, it felt like to me you were seeing so much more, and per the surgeons, they had more of these degrees of freedom and ability to get into these different planes. So I think it seems like where we should be going for most cases.
From a selfish standpoint too, personally, because I'm sitting and doing the same surgery versus standing up at an operating table, either holding a retractor or, just the physical stress of surgery is less, which I think is better for career longevity.
And what he's not telling you is also longevity of his golf game.
Well, that means more work. So.
Yeah, his back's going to hold up longer.
Right, that's what I'm saying.
he's
Yeah,
gonna
longer
get-
playing career.
Yep. I like it. In ideal circumstances, we're meeting in a multidisciplinary conference when you have a new patient diagnosed with either colon cancer or rectal cancer, and we're talking about the treatment approach together. And we just want to walk through the audience on a potential case and how we would approach it. So if you have a new patient with a new diagnosis of colon cancer, the staging is important, right? That kind of tells us how we should approach the treatment, whether we need to involve, chemotherapy, which is kind of my specialty, whether we need to involve radiation therapy. For Rick, it's usually rectal cancer cases that the radiation oncologists get involved. But for a colon cancer case, Stage 1 and 2 colon cancers are primarily treated with upfront surgery, and including stage 3, which would be a lymph node involvement. And Alex, could you tell us a little bit about how your surgical techniques might differ for those kind of cases? Does it even change in terms of the number of lymph nodes you remove, or kind of the resection, how wide of a resection you do for those cases?
Absolutely. Yeah. So like you touched on staging. I think it's important for patients to know, every patient, they want to know what stage are they, because that's what they hear on television or someone in their family asks them. I try to reassure people because sometimes we usually get preoperative CT scans to look if the cancer has potentially spread. And that's technically a stage 4, which people look up on the internet, and it's scary. But I try to kind of reassure them, don't get too involved with Dr. Google because every stage is treatable. They are all treatable. Right. The sequence of treatment may change. You may get chemotherapy before surgery, or you may get a different kind of surgery, but 1 through 4, it's all treatable. So I think that's important. But then if we know up front that it hasn't spread and it's a colon cancer, we usually do upfront surgery. And the way we look at it is we have to get what's called a margin. So we typically want about 5 centimeters on either side of the lesion to make sure that we've gotten out enough normal colon that there's no microscopic spread of the tumor. And then the standard of care is that you need at least 12 lymph nodes as well to make sure you've adequately staged those The lymph nodes are microscopic, typically, unless they're very enlarged for some reason. I don't see them in the surgery. But so when I go after lymph nodes, it's basically based on certain blood vessels of the colon. So on the right colon, there's an artery called the ileocolic artery, and on the left side, there's different arteries as well. So I have to find those in the operating room and basically take part of those arteries out with the colon, and that kind of ensures that we get enough lymph nodes. And then, the pathologists help us by finding them microscopically, which is fairly tedious. But basically, I try to treat every colon cancer exactly the same, just to standardize my approach to making sure we're surgically doing a good job and also getting you guys enough information to treat them, with the newer chemotherapies and other types of therapies that are out there now.
Right.
But that's basically it. I go and find a blood vessel at the beginning of every case, start there, and then I take out the other part of the colon.
Yeah, I think colon cancer too there are other cancers like this, but I think still one of the, I would say, less common situations where so much of what guides therapy is dependent upon what you do at surgery, Alex, what you remove, and then what the pathologists see under the microscope. Because I think we've all seen cases where patients get a CT scan or a PET scan and you see some very large mass, or it looks really, really bad on imaging, but then when it's removed and they look at it under the microscope, it may have been big in size, but it wasn't very invasive, or it didn't spread to lymph nodes. So I think that's, unlike other cancers we treat and have talked about obviously on this show before, I think that's what makes colon cancer a little bit unique. For folks who don't do this regularly, I think it's a little, counterintuitive for them. So I think it speaks to how important it is to get the appropriate surgery done and then the appropriate pathological staging, and really how you're really are the captain of the ship with colon cancer. Because if we don't get that information, or we don't have all those tools, then Danny, you can't make decisions you need to make on the adjuvant side. Prognosis can't really be informed that well. So I think it's just something to for the listeners to hear, just because it is a little different than some other types of cancers we've talked about.
Yeah, it's almost impossible to give patients that prognostic information, treatment recommendations until the surgery is done, until the pathologist looks at the specimen and says, "This is what I see." So a majority of the time we're seeing patients after surgery and going over the pathology with them to kind of guide the treatment from there. So
I think patients always want to know. A frequent question I understand is, how big is it? How big is the tumor? And we try to explain to them that it could be 1 centimeter, but very invasive, or in the lymph nodes. And that's something you want to worry about a little bit more than something that could be 10 times that big, but it's very superficial, hasn't gone anywhere. So it's unlike some other cancers like breast cancer, other things you guys I'm sure have touched on, where until you really break it down microscopically with the pathologists, who are a key part of the team, you don't know what the stage is going to be sometimes. You don't know what the treatment plan is going to be. And the only way to figure that out is by doing the surgery there.
Well, I think it also speaks to your earlier point about the upfront staging with the imaging, where even if you find a cancer spot in the liver that we think started in the colon and we prove it, there are different, we now know, thanks to better information and clinical trials, that stage 4 disease is made up of multiple types of patients. So not all stage 4 disease is what we traditionally thought of as incurable, short-term prognosis, that sort of thing. So avoiding the Google machine, and I say the same thing to my patients, is key, because your situation is your situation, and we're giving you the recommendations and the information based on your situation, not necessarily if you just Google your generic diagnosis, because there's a bunch of information out there that some of it may be relevant to you and some of it may not be relevant to you. So I think that's just important to touch on too.
All right, Rick, I'm a little disappointed I didn't get to tell my dad joke in the beginning of this part 1 of colorectal cancer. Can I tell it now?
I see your tears, so I guess we'll allow it.
All right. What do you call a chameleon who can't change colors?
A chameleon can't?
A reptile dysfunction.
Nice.
Thank you. Thank you. I tried it on my wife earlier. She didn't like it very much, but I.
All right, so moving on. So producer Brennan was right. This episode clearly is going to extend into 2 parts. Dr. Crean, thank you so much for your time, and we look forward to continuing this
Thanks for
conversation next week on the second part. But with that, I think we'll close it out till next week.
Thanks so much for coming back and joining us for another episode of Medical Minute.
If you have any suggestions on things we should talk about, questions you'd like answered, or you just want to say hi, please email us at medicalminute@csnf.us.
And make sure you follow us on social media. Search Cancer Specialists of North Florida on Facebook and _CSNF on Twitter and Instagram.
As always, we appreciate you giving us a few minutes of your time, and we hope you learned something today.
And remember, when it comes to your health, and remember, when I'm having trouble reading. And remember, when it comes to your health, stay informed.
Ask questions
And
and tune in next time.